I will now call to order the meeting of the Potter Valley Healthcare District Hospital Corporation, also known as Watsonville Community Hospital, for Wednesday, October 29th. Rosie, you can please give us a roll call.
Yes, Director Cox. Here. Director Friel. Here. Director Gallagher.
Here.
Director Pimentel.
Here.
And Attorney.
Here. Okay, we have no action to report out of tonight's closed session. So I'll move on to agenda modifications for consideration from staff. Any agenda modifications from staff?
No agenda modifications. Is this when we do the?
No, we'll do that. We'll get to that.
That's what I thought. You were looking. So I made me second guess myself.
Sorry.
All right, I'll move us on to public comments on matters not on tonight's Hospital Corporation Watsonville Community Hospital agenda. Rosie, if there's anyone wishing to speak on my matters not on tonight's agenda online?
No hands raised online.
Okay, anyone in person wishing to speak on matters not on tonight's Watsonville Community Hospital board agenda? Okay, close down the public comment and I will bring it to comments from our board members. Are there any comments from our board members before we get started at tonight's meeting?
Chair, comment, just wanted to honor a good friend of this board and a member of our community that passed away, Jesse Placencia, is married to a former board member, Marcelo Bates, who stepped in at a time when we needed help on our hospital board. And truth to be told, he's always been in this community helping and was always dragging her husband Jesse, and often just dragging her. And Jesse was a huge volunteer in our community, volunteering with local fishes. He'd often be behind the scene running fundraisers for any event you'd see. He's just a really incredible soul and a big contributor to a lot of things behind the scenes for the community. I just wanted to acknowledge Marcella's time here, acknowledge what she's going through, and then her deepest sympathies and thoughts and prayers for Jeff.
Thank you, Marcus. Anyone else wishing to speak? Any other comments from the board? Okay, I will now close down the comment from the board members and moves on to the consent calendar. We have three items I believe we have three items on tonight's consent calendar. We have minutes approval for our previous meeting in September 24th meeting, our policy and policy summary approval for October 2025, and the Watsonville Community Hospital 2026 board and committee meeting calendar. Any questions for staff before I open this up to public comment for items on the consent calendar?
Can I do it now?
You can do it.
So Chair, we're going to pull a couple of the policies for just ensuring that we've got the right formatting and some errors that we identified after we submitted the packet. So I'll just read those off. We're going to pull those off and we'll bring them back next month. So the safety management plan, the security management plan, the hazardous materials and waste management plan, fire safety management plan, the medical equipment management plan, and the utility system management plan. We're just going to make sure those are, everything's dotted and crossed and bring those back next time. Okay, pull them off for this one.
Okay, Rosie, if the record could reflect that for the minutes for this meeting. Okay, any questions for staff?
Steve, as you went through, is the EOC management plan among your list to be pulled?
It was.
Any other questions from the board for staff? Okay, anyone joining us online wishing to speak on the consent calendar?
No
Okay.
hands online.
Anyone in person wishing to speak on any of the items on the consent calendar? Okay. Seeing none, close down the public comment. I'll bring it back to the board for an appropriate motion on tonight's consent agenda.
I'll make the motion.
Did I have a second?
I'll second.
Thank you.
Thank you, Directors Friel and Cox. I will take roll on this item. Director Cox? Yes. Director Friel? Yes. Director Gallagher?
Yes.
Director Pimentel?
Yes.
And Attorney.
Yes. Okay, we've gone to our public hearing for tonight. Item number 4, this is Government Code 3502.3, public hearing on Watsonville Community Hospital vacancies, recruitment and retention. Contact here says Margaret Morgan, but
Yeah.
I have subcontracted.
Oh, okay. Oh, and, Andrew, whenever you're ready.
Good.
Give me just a moment to show this online as well.
Good to see you again.
Good to see you too. Been a while.
All right.
Okay, now should I explain AB 2561?
Let me introduce Amy Baker.
There you go.
He's our recruiter. It's awesome.
Yes.
A lot of work for us and been here for a while.
Thank you.
Thank you.
Yeah, well, first of all, thank you guys, because speaking of jobs, I know this is not a very high-paying job, but you guys, well, I'm very appreciative of having you guys and everything you do for the community, so thank you. AB 2561, as of January of this year, public agencies are required to submit vacancy rates for bargaining units to ensure that we are below the threshold, and also that we're not holding positions for budgetary reasons. The bargaining units would have the ability to look into any of that. So I'm here to tell you, it's good news. We are able to hire. We are a desirable place to work. If you look at the next slide, I have the vacancy rates for total positions within the hospital, and also on the very far right side. Specifically, what AB 561 is looking for is full-time positions. So for each of the bargaining units, you can see that they're below the 20% threshold. Caltech, which would be our radiology positions and some of the respiratory positions, do have more vacancies. That's a little bit tougher to hire for, which I'll discuss in a minute. But as you can see, it's below 5% vacancy rate for all other positions and even non-union leadership positions. So people like working here, people want to work here, and I think in other talks you guys discuss retention rates.
Yeah, we report our retention rate. It's about 85% retention, which is very good. So he's not just filling positions because we have a high turnover. We have a very relatively low turnover, and he's still hiring.
On the next slide, this is just a snapshot of, hires in 2024. 156 total, 57 of those nurses. On the next slide, it's 2025 to date. Actually, as of a couple hours ago, that number has increased. Hired some more today. Again, this doesn't have as much to do with AB 2561, but it's a snapshot of what's going on. In terms of recruitment efforts, we hire based off of what ELT approves, mostly replacement positions for union positions that have been vacated. People have moved into other different shifts or retired, moved on to other places. A lot of people like to come back once they move on to other places because they find the grass is not always greener. So yes, once the positions are approved, I post and recruit for the positions. Positions are posted on our website, and then they're scraped to different job sites, the big ones, LinkedIn, Indeed, JobVite, whatnot. I rely on our applicant tracking system. I go back and look at old applications, people who may be interested in new opportunities that we have. In terms of retention efforts, we do have attractive wages. For the most part, we're within market. On our benefits are at market rate. And, employee recognition, town hall, leadership efforts, engaging the employees, and just the sense of community. I think one of the big things that we look for when we're talking to candidates is how much they are invested in the community, how much they care about it. And as it is a labor of love, people find that, when they come here, they are a part of that family. So that does help along with the recruitment efforts to really talk about that. Hiring challenges would be some of the uncertainty of the hospital's future. Just trying to figure out where we're going to go. But still, again, even through that, we've been able to bring people on and people are excited about the future of the hospital. In terms of some of the leadership positions or non-union, some of the retirement matching, not having that has been a challenge, specifically for
like labor and delivery, we have a lot of openings on the night shift. Currently, we have two, potentially more. But, night shift LNP is always tough out.
Right.
Yeah. And then in terms of, the radiology positions, there's just not enough candidates out there and a lot of clinics and other hospitals. So that's a challenge, but we did just hire a CT tech, so that's good news. Another MRI tech. But yeah, I would say that the L&D nights and radiology would be the most difficult so far. Any questions?
Does Cabrillo still have a red tech program?
I think that they have a pipeline, but yeah, and we don't have any students
Okay, that's what I'm.
on site for Cabrillo, which, yeah.
Any other questions for Andrew before I open up the public comment? Just real quick, Andrew, in terms of vacancy rates, what do we determine as a vacancy? And is it just when a job is open at a given period? And then same sort of question for the retention rate, is it if an employee crosses a certain threshold, then they are considered retained, or how we define those?
The amount of employees that we have, and in this sense, it's full-time employees, but I did highlight both, including the per diems, but the amount of employees we have, and then adding the amount of vacancies, and then that's what vacancy rate.
Okay.
Yeah.
And same thing with retention.
Mhm.
So we take total number of positions, including, and it's a rolling 12-month period. We're just tracking full-time, because that's, there's,
Right.
it's really come and go a lot. And then we don't include people who pass away or.
Sure. Okay, thank you. If there's no other questions, then Andrew, thank you for the presentation, and I will open it up to a public comment on this because it is a public hearing. So Rosie, are there any raised hands online wishing to speak on this item?
No hands on mine.
Anyone in public wishing to speak on this item? Okay, seeing none, I'll close it down, and I will thank Andrew once again. Thank you for the presentation. And
Anyone want to update on the World Series? Student not included.
Okay, thank you. Okay, moving us on to item number 5. This is the Medical Executive Committee reports approval for October 2025. This is a report that the board received in closed session. Are there any questions from the board or staff on item number 5? Okay. Seeing no questions, I'll open it up to public comment for item number 5. Are there anyone online wishing to speak on item number 5?
No hands on mine.
Okay, anyone with us in person wishing to speak on item number 5? Okay, seeing none, I'll close down the public comment. I'll bring it back to the board for an appropriate motion.
Move to approve.
Do I have a second?
Second.
Thank you, Directors Cox and Gallagher. I will take roll on this item. Director Cox? Yes. Director Creel?
Yes.
Director Gallagher?
Yes.
Director Pimentel?
Yes.
Chair Davis?
Yes. Okay, we'll move on to item number 6. This is the Chief Financial Officer monthly financial performance update. Julie, whenever you're ready.
Okay. September, we struggled again with net revenue and volume. So we ended the month with a almost $1.9 million loss. As you can see, we were short in our net revenue by $3.5 million, favorable in operating expense by $1 million for the month. Primarily what we saw as it relates to the net revenue, lower volume, so fewer patient days. We were about 18% below in admissions and patient days. And we ran an average daily census of 27.8, so we were about 6 days below what we had projected. We also saw some unfavorability in the payer mix, and I'll show you that in a later slide. And then that was primarily on the inpatient side. And then the service mix, and you'll see this in the stats, that this was a month with lower volumes in deliveries. Surgeries were down a bit. Our robot assisted cases were down a bit. And we even saw a slight decline in our non-emergency department outpatient visits. Next slide. So on a year-to-date basis, we're almost $16 million loss. As you can see, the net operating revenues is primarily driving that, as we're almost $26 million behind budget there. And we're about $8 million favorable on the operating expense. It's pretty much been the same story every month, where it's been lower admissions than planned. Some of that has to do with the fact that we had planned for some pediatric admissions. Some of the lower outpatient visits, especially on the outpatient surgeries, relates to not starting up the cath lab and having the volume that we projected for the cath lab. And then, you know, we suspect that some may also be immigration related fear of coming. Generally speaking, on the expenses, we're managing productivity and to volume, but at the lower volumes, as we've said, it is definitely hard to flex all the way down due to core staffing needs. We have some overages in contract labor, primarily as Andrew was speaking, L&D nights. We fill some of those with contract labor. We've had some leave of absences that we also have to fill with contract labor. We've seen some higher than expected costs and things like cafeteria food costs. Our implant costs are over budget. Some of our lab reagents and things that we use for the lab have been over budget. And then we have things like the trailer rentals and purchase services for the CT trailer that we've had for the last few months. Next slide. So this is a deeper dive into the net revenue, and pretty much like it's been in the last few months, you know, between volume, service mix, and then collections, which tends to be a bit about your payer mix change and sometimes aged AR. You know, those three are roughly in the same magnitude of order, and they, you know, make up a good, you know, probably 80% of this. Last month, we reported that we had done a bad debt adjustment for some of the very old aged AR, just changing to the standard methodology that most healthcare providers use, where we write down all the AR at 365 days, even though we still have it with an agency to try to collect on it. Those collections are usually minimal. So that's why bad debt is at 8%. And then, you know, there's a portion of revenue variance that just relates to the case mix and our FOP and DISH. Next slide. So as I mentioned, you know, volumes being lower and being down about 18% in our admissions. We also saw that our surgery cases were down a bit. We did see some increase in general surgery, but it's offset by some decreases in other areas. And then, you know, primarily on the non-emergency room outpatient visits, the rehab department had some lower visits this month than what they previously had. One of the things that they have done is they've been kind of trying to right size their daily schedule in terms of how many hours are open when they have demand. And I think that might be a partial contributor. Next slide. So on the year-to-date basis, the admissions being down 14%. I'd say peds, the lack of a peds program probably accounts for about 4% of that, and then our overall admissions being down about 10%. Length of stay has been pretty steady. We're a little bit below budget this month, or a little bit below budget on a year-to-date basis. Deliveries, although they were down this month, pretty close to budget. Inpatient surgery is up a bit, and I'd say most of the outpatient surgery decline relates to the cath lab and a little bit to where we've had some holes in physicians that we're filling in these next couple months with ortho and general surgery. The emergency room visits, well, they were down a little bit last month. They tended to recover this month. I think we averaged about 93 visits per day on the ER side. Next slide. So here's payer mix, and as I mentioned before, where we really saw the decline this month was in the commercial mix. This month, we had a pretty low commercial mix. Oh, yeah, it just a little over 12%, where, you know, the last few months, we've been more in the 15, 16, 17% range. We had a bit of a pickup in Medicare, and what we've been seeing over the last, you know, couple months is a little trending upwards of the managed Medicare product. The Alliance was down a bit, and everything else is relatively flat. Next slide. Outpatient was more consistent with prior months. Little bits of shifts here and there, but nothing more than a % shift up or down. So it's really pretty consistent. We were at 23.4% commercial for the month of September. Next slide. So just to kind of recap on where our budgeted initiatives have met or exceeded budget and fallen short, the blue being favorable results and the orange being unfavorable results. You know, the largest favorability has been in our ability to kind of manage our supply expense to the volume that we've had. That's easier to kind of manage than it is staffing, which is one of our orange bars is staffing. The other positive things, the loan forgiveness that we had from Santa Cruz County Bank, I mean, not Santa Cruz County, Santa Cruz County, we successfully kind of concluded that recovery of a loan forgiveness. We've had some good success with the 340B program and continuing to work there, but that has had a favorable impact to our EBITDA this year. We have a few cost avoidance items because we haven't had the cash, so we haven't done any non-union increases. We haven't been able to fund any type of leadership retirement. And then on the unfavorable side, our largest unfavorability is been kind of it within our radiology program as we've gone through various transitions. Always up front, when you're first bringing in a radiology group, it's a little bit more expense until they get some collections going that start to offset some of the cash outlay to them. So they're kind of at that point where that tide is changing a bit and starting to see some of their collections. And then the lack of the pediatric volume and the cath lab volume are the next largest items. The few that are just fairly small, you know, one of them was the LED light upgrade, which we've just recently pretty close to completion. And so going forward, we should start to see some improvements to our PG&E expense, but there's a bit of a timing lag there. Next slide. And then as my final slide, I'm just changing direction a little bit, but just to give an update on cash, as we've talked before, AP continues to be a challenge. We're managing our accounts payable disbursements very closely every week with a very detailed review of what we are paying, what we're not paying, how it's impacting operations from either a call coverage ability or a getting critical supplies in-house. And so it's very much just-in-time management of the AP. And it's, as I say there in the third slide, really, or bullet, really to work hard to not be put on credit hold, not be stuck in a situation where supplies aren't delivered. And, you know, making sure that we have the supplies we need for patient care, and also making sure that we're not over ordering just because it's been a regular pattern, so it's very much checking in on, is it needed for cases next week or this week? It really does tie back to the fact that our volumes have been down, so what we would consider an ideal AP disbursement, our revenue is not currently able to support that. So we are cutting and going into payment plans and having many discussions with our partners about payment plans, renegotiating payment plans, sometimes why we've missed a payment plan. And then the other piece of that is we continue always to look at what funding sources might be available, how else might we generate some cash. We have our upcoming first payment towards the voluntary rate range program, which is one of the new intergovernmental transfer programs that we're going into for this next year. We're right now on pace to do 2 of those for 2026. That I'll take questions.
Any questions for Julie about this thing? Or for anyone on the team? I know that Marcus and for Director Pimentel and Director Gallagher have thorough review of this in the Finance Committee 2 days before this meeting. So any additional context you'd like to add for the board? Okay. Okay, I will open this up to public comment. Anyone online wishing to speak on item number 6?
No hands online.
Okay, anyone in person wishing to speak on item number 6? Please.
So Jennifer Gavin, I'm the Director of Pharmacy and Respiratory. I wanted to acknowledge Julie and her team. What she does and what they do every week is rough. And so I'm usually at the end of it where I'm asking for money. And her team has been very, very good at listening to our requests and helping us prioritize. So it's rough. And so I'd like to acknowledge and all of you. And I know what you do and I appreciate it. Thank you. Yes, I will. Margaret said this means I'm gonna get more money. Don't let me.
Okay, there's no one else wishing to speak on this item. We'll close down the public comment and thank Julie for the presentation. Steve, we'll move on to item number 7, it's the Chief Executive Officer report. Thank you.
Thank you, Drew. Yeah, I'll give you a minute. So we're gonna keep this as listed as the Chief Executive Officer. Trina and I are gonna start doing this as a combined leadership report, so we're gonna just sort of make this a more formal thing where I've got some slides and talking points and she does as well, and we'll try to be seamless in that way. All set? Sweet, let's see if mine works. Want to share updates and progress on what we are using our bond dollars for. So we have started the construction for the radiology upgrades. So the MRI, the CT, and the fluoroscopy room construction has begun. The pictures that you see here are of the old MRI being removed from the facility. So this was kind of a big deal last week. We have, as the old one is being removed and we work on the installation of the new one, we have a trailer outside the mobile unit outside the emergency department for MRI. That mobile unit is ready. The staff has made it ready. The state has not given us approval to use it yet. So that has been a frustrating challenge. And we have escalated that in a number of different ways and continue to work very hard on it. But I want folks to be aware that MRI services are currently not available because that MRI trailer, we are not allowed to use it yet, though it is ready for us. So we'll let you know as soon as that changes, because that would be a momentous positive occasion. And we hope that it will be within the next few days, but we are really at the mercy of the California Department of Public Health. Good news on the labor and delivery front. So we have implemented and rolled out for our patients donor breast milk. So for new moms who are unable to express their own milk for their babies and want human milk going into their babies and not artificial formula, we are now essentially a donor breast milk bank within the walls of our facility. Kim Niquillo Sanchez here in our audience as our Director of Women's and Children's Services. And our wonderful pediatricians have presented this at a recent Stanford Medicine symposium as a poster. And this poster lives in the department now, talking a lot about the improved outcomes that donor milk provides for our infants, including the optimal nutrition, family support, equity in care. This really helps close gaps in access for families that might not have access to this option otherwise, and really just the lasting impact. So Kim, thank you for your leadership on this, and to our OB and pediatrics departments, wonderful work for our moms and babies. I was fortunate enough to present an update of our hospital and our healthcare district to the Monterey County Board of Supervisors on October 7th. That was very well received. The County Board of Supervisors in Monterey were extremely supportive of us and the work that you all and the staff have done over the last couple of years, and they're supportive of the future direction and what we're looking at in terms of strategic partnerships and bringing more services and strengthening services here in our geography. It was a really nice welcome that we got from them, and a really warm reception and positive feedback that we got from them. So that was nice to see and experience. I just pulled the last couple of recent online reviews because they're really great. You see them in your packet, so I won't read them out loud to you, but one of them is like the first one that pops up when you first open Google and you Google Watsonville Community Hospital. And another one was the 5 hours ago one was the most recent one on that particular day. So I just pulled those two. They were both 5 stars, and I'm just going to show those because they're really great. But this is, one of them is about the first one from a week ago is about somebody who had their 3 children here and how the labor and delivery experience was fantastic. And the other one is about a visit to the emergency department and how everybody in the emergency department, all of the various providers, list of providers that they saw were wonderful. We see that every day, and so we appreciate our patients noticing it. So along those lines, I wanted to just drill down a little bit more on our dashboard item, which is our HCAHPS, our patient experience scores for our inpatients, and just wanted to zoom out and look at overall trends from the last few years. This is for, most of these are for 2022 through 2025. And so for our overall patient satisfaction, where the one on the left is the rate the hospital on a scale from 0 to 10, and the one on the right being your likelihood to recommend the hospital. We do have overall trends over the 4 years that are positive, but we have backslid a little bit from 2024 to 2025. So I do want to acknowledge that we've regressed to the mean in these areas. So a little bit just below now the national median for those. For the dimension of communication with nurses, similar story, really. So some couple of areas where we peaked in 23, others where we peaked in 24. Overall, trend lines up, but 25, we've come back a little bit on these areas. So continued work here, and some of the things that Trina's going to talk about, speak to some of the things that we're doing around this. Communication with doctors, I think overall this is trending pretty positively. 2 of them, we've got our best scores in 2025. 2 of them are not, have come back a little bit. So overall doctor communication up to the 43rd percentile, still not where we'd like it to be. We'd like to get to the median and better. But it is trending upwards slightly. And the doctors explained in a way that you can understand, said it's best ever at the 67th percentile nationally. The other couple areas, we still have some work to do, and we've presented this to I presented this to Medical Executive Committee last week. And the physicians are helping partner with us to spread the word here and see what we can continue to do to improve these numbers as well. The overall hospital environment, so the hospital cleanliness and the hospital quietness. Hospital cleanliness blew that out of the water in 2024, which was awesome. We've backslid back towards the median, but still much better than the prior years for year-to-date 2025. And quietness, I would say that's pretty steady, you know, a bit of an overall increase and a bit of a drop back from last year, but those are all pretty similar percentile rankings for quietness. Here's one where we can acknowledge Jen and her team, but also the nurses and the doctors as well. These have trended really great, the communication about medicines. So the one on the left is the staff tell you what the new medication that you're receiving is for. And the one on the right is the staff describe the medicine's side effects. And so both of these really great trends, 85th and 94th percentile nationally. That's pretty fantastic, obviously. In the top 6% of all hospitals in the country on that latter one. So wonderful, and wanted to acknowledge that for sure. I think we can take questions as a group at the end. I'll let Trina keep going with her part of the report. Do you want this? You want me to do this?
Sure.
I'll do it.
Sure.
Okay.
It's fine. All right, so quality and patient experience. The first quote there is from compliment that our quality director received and shared with me from a daughter of a patient who was recently seen here. She was very excited or very happy about the care that her father received from Francie, one of our ER nurses, and felt that she was very compassionate and caring. And I just felt kind of a testament to, again, just kind of a repeated theory throughout our hospital of the nursing care that our patients are receiving. And then on October 14th, we completed our second heart cath. Thank you to Kirsten, our cardiovascular services line director, for her continued leadership and making this be another successful heart cath. And we included a little picture of the team there. So thank you to her and to the PACU team and the cardiovascular service line for another successful patient. Clinical services and access. So for the emergency room, we are continuing to have some gaps in our ED on-call coverage in November. We have spoken with our medical staff office, and our leadership is all actively pursuing solutions to getting these shifts filled. But currently we do still have some gaps remaining. For supplies, we are still definitely having some challenges with getting our supplies for various different reasons, especially related to our laparoscopic and robotic surgeries. But to date, we have not had to cancel any surgeries because of supplies. We've been able to manage getting those in just in time. And then MRI, like Steve said, we're still without being able to utilize our trailer that is out in the parking lot, which has evolved to an uptick in some of our emergency room transfers as well, because of not having that service. And then for operating room, this is more of a shout out to June and to our donors. June has successfully fundraised over $600,000 for the equipment for 2 of our ORs. And we expect to see some of the renovations with that starting after the first of the year. So for talent and culture, Steve has done a really nice job having some town hall meetings, and one of the things that we've kind of heard repeatedly from staff is that they felt that the communication could be better. So to increase transparency and communication, Steve and I developed our first newsletter that we sent out Monday this week to all staff. And it is also posted up on the Compass for anybody who would like to read that. And then we'd also like to develop a new ad hoc committee on how we can improve communications hospital-wide using some of our resources, like even on the WOW, on the screensavers on the WOWs, things like that, that we can improve our communications. But it definitely needs to be a multidisciplinary committee to make that be the most successful. Another thing that we'll be working on in 2026, I'll be working with our quality director, Michelle, is implementing Just Culture. And Just Culture is really, it's a system that values a system of shared accountability between the organization and staff. So the organization takes responsibility on the systems that they have in place, and then staff take accountability for their actions. And the goal of the program is really to increase self-reporting of errors. It's to build trust between the staff and the organization so that they feel more comfortable in self-reporting errors, and not fearing, punitive discipline or anything like that. And this allows us to look a little bit deeper, whether it's a person problem or it's a system issue, and so that we can, improve safety for our patients overall. Annual skills day by December, beginning of December, we should have all of our clinical areas will have completed their annual skills day. Again, thank you to Kirsten and Cecilia and Zach for that. Talent recruitment, our HR department is hopping. Thank you, Andrew and Margaret and Gabby. We had 12 new RNs start on our new hire orientation on October 20th. And we also added 2 radiology techs. And then welcome Allison. She's our new program manager of employee health. And she comes with a wealth of experience, and she's working with quality and myself also to implement a lot of new programs here. So more to come on that. Any questions?
Any questions for Steve or Trina from the board? Any questions? No. I do have a couple questions. You good? So for, do we have a completion date or quarter or timeframe on the OR renovation, like when that might be ready?
So I don't have a completion date. I have a start date, which is going to be after the radiology work, just because we only have so much bandwidth to be able to do construction renovation projects. So we're going to start that with likely beginning of the first quarter
Of 26.
Once we feel like we've got a handle on the new MRI and the CT installation.
And then we had the second case for the cath lab. What does the volume look like for that kind of near future? And then I'm sure, I think in the budget, we're looking at it as an initiative, as a new initiative. What does the volume look like for that line?
I think the answer is we're working on that. I'm looking at Kirsten because she's over there, and I know she's working on that and what we think those are going to be. So I don't have those. Unless one of you feels like you do, I don't think we have that number in terms of, but it will go into the budget, what we feel like the volumes will be. also want to be cognizant of not overdoing that like we did last year.
Right.
Where we were pretty aggressive with what we thought we would be able to get to. And it's really position dependent, so that's, we want to be cognizant of that, so we don't have those numbers at this point, what we think it will be.
And then just for my knowledge, I think so what allowed us to do the second case with, we had coverage on that day for that line or?
Yep.
And who's the doc who performed the case?
That was Dr. Joy, right?
Very cool.
Dr. Joy.
And then, kind of going back to the MRI, to the trailer, have we reached out to any of our partners at the state legislature
Yes.
for assistance in that?
That is who is assisting us, yes.
What has the response been so
The
far?
response so far has been, thanks to the escalation, we have escalated the priority on this,
Mhm.
but they still haven't given us a date.
Okay.
They initially told us 100 days, and we were like, that's like as long as the entire construction project is, that's not helping. And
Right.
so we went to our state senator, whose office has escalated, and we were trying to get help that way. And we are getting their attention, but we haven't gotten a date yet.
Okay. Yeah, we had similar case over at, getting approval for the license over at, Elder Day at my work and, you know, worked with state legislature and exactly, I think we had 180 days was the first initial kind of thing, trimmed down, I think, by 2 or 3/4 or something like
Yeah.
that. So it's great. Just any way that the board can help in that sort of way, but, so would be happy to help. And I think that's all I have for right now.
Director Gallagher.
Can I jump in and say?
Please.
Somehow Adult Ed was able to get a certification on something that they needed. It wasn't the equipment, it was somebody certified to be able to teach a class. They did it in some short period of time. Nancy Villasich might know the details. I don't, but
Okay,
might be worth a call.
okay.
Any other questions? Okay, I will open up to public comment on this item, and I think we're doing just fine on time. Anyone wishing to speak on this item, please, online, please raise your hand.
No hands online.
Okay, anyone in person wishing to speak on this item? Okay, close down the public comment. I'll bring it back to the board for any closing comments on this item before moving on to item number 8. Okay, we'll move on to item number 8, Julie, 2026 budget update, whenever you're ready.
Yeah, I'm gonna do a brief budget update. We're still working on the budget. And so most of this update is really gonna talk about where we're at from a base budget. And then we'll talk a little bit about the initiatives and things that we still are trying to quantify and solidify for the budget. Go to that first slide. So just as a reminder, we've talked and brought before the volumes. And just to kind of put a little bit of context behind some of the numbers that you see, is a reminder that we took a much more conservative approach. We actually budgeted a reduction in admissions and days and ER visits. We had initially looked at some volumes in about the June timeframe. Then we had that very slow July. And in August, we reevaluated what we had kind of proposed in June. We, at that point, also had knowledge of, you know, things coming as a result of the HR1. And while we don't have any exact numbers behind that, we just kind of sense that that was also a reason to be extra conservative. So we did budget, as you can see here, a 10% reduction to where we kind of expect to end the year at. And a 9% in the days, because we did account for a little bit of extra length of stay. Our length of stay is low, but you know, it only takes a couple of patients to move it up a notch or so. And it will still be a fairly low length of stay. I think we're budgeting about 3.6 days and we're running, you know, closer to 3.3. A slight reduction in the emergency room visits, really where we did put some increases is this year we've been pretty steady growth in the outpatient, non-ER visits and expect to kind of continue to see that happening. This is not including anything new that might come out of, a, second CT scanner or a more efficient MRI. There's some, CT and MRI in the base budget. And then as we try to think about what those incremental adds are, we will add those as an initiative. We do have some increases in the total surgeries. Again, this is not including anything from the cath lab, but just our current book of business. And this is also not including where we might see some new growth and ramp up with a new ortho and a new general surgeon. This is basically somewhat what the current volume and run rate was in 25. And then also the increase in deliveries. Next slide. I'm not gonna spend too much time on this slide because the slide after this is a little bit more descriptive. And this slide was kind of that first, what does EBITDA look like? But it looks more favorable here because we do have some of the QAF 9 projected. But what's not in this view is what we're thinking about related to HR 1. So I want to just jump to the next slide, which drills this out a little bit more. Unfortunately, the numbers get a little smaller when I add columns, so I'll kind of walk you through what we're saying here. I'll look at it myself. So, we're, on a run, a negative, 16 million through September. So assuming that volumes and things are, kind of the same as what we've been seeing most of the year, that puts us on pace for about a $21 million loss for the year. Where there's a real potential for pickup is if this QAF 9 program is approved. It's, not yet approved. It's with CMS. They are reviewing it. The consultants we work with say they're optimistic that it could be approved. Maybe not exactly as modeled, but more on a favorable side than a complete decimation of it. So right now, this view shows if it was approved at 75% of what it was modeled, that that is helpful to us. I realize I just skipped a column. The one after the 25 annualized is the base budget before I start to talk about QAF 9. So that's more existing with the remainder of QAF 8, but no QAF 9 in it. And that just pencils out to a $13 million loss before any kind of initiatives. So with that QAF 9, even at 75%, that picks up $11 million. If it was at 100%, it picks up closer to $17 million. We then have, brought before the estimation of what HR 1 can do in that first year. We've said, over 10 years, it's anywhere from 98 to 130 million or so. In the first year, we're kind of estimating it out based on, the best knowledge we have from CHA analysis, some of the analysis that the Alliance has done, as it's probably a $4 to $6 million potential hit to our revenue. So we've just kind of chosen the midpoint, which is about 4.9 million as a negative there. So what that does is that brings our base budget down to about $6.7 million loss. Then the one thing that is working in our favor is these new intergovernmental transfer programs that we're working towards, one being the voluntary rate range and another being the private hospital supplemental fund. The voluntary rate range one is coming up quickly with a payment into the program in November and receiving funds back in February, which will then turn around and add some additional funds to make the private hospital supplemental payment in April and get back money in June. So we've budgeted for that, plus we have we have projected that in October, November of 26, we would be making another payment towards the voluntary rate range program for 27. So there's an extra expense in here where there's not, for the 27 program, we wouldn't receive the revenue until 27, so that's not in here. But so the net of those programs is about a almost $2.4 million pickup for us. And so that brings our base budget currently in its current state at about a $4.4 million loss. We can go to the next slide. So then the initiative work is where we're still trying to quantify and get some comfort level on what sort of volumes, what sort of added expenses. We may be able to see how much of that $4.4 million loss can we reduce. So as we've mentioned before, we're really reviewing the cath lab and the whole cardiovascular service line, looking at the pro forma that was completed before, where we should tweak that. And as we've said, that's very dependent on having physicians to refer and do cases here. With the MRI and CT, you know, we do expect some volume growth, so we have to kind of nail down when in the first quarter we expect that to be implemented and in service, and then what type of ramp up. So we're working with our radiology director there. The orthopedic volume, as well as, it's not mentioned here, but general surgery and even our primary care providers at Coastal Healthcare, working with Lupe, the clinical director over there, to, you know, anticipate what sort of new volume above this year's base we could plan for. What is not in here and may not have enough information by the time we need to close this budget is what sort of impact strategic partnership could have. So we mention it here, but we're not certain that we're going to be having enough information for a budget line item. And then there's always revenue cycle improvements to be done. So we are certainly, we're working with our new revenue cycle director on what we can quantify. Right now, there's been a huge focus on things that from a process standpoint, making sure that we have more efficient scheduling, making sure that our billing and collections vendor is appropriately addressing aged AR, looking at other ways that we might generate some cash acceleration. But we are also going to look at what can we quantify and feel confident about as a budget line item to improve collection revenue cycle revenue. And there's other things that we're still, you know, seeing if there's something else that we should be looking at and adding into our kind of initiative buckets. So with that, I'm open for questions.
Any questions of Julie?
I want to echo, not questions, commentary, right? I want to echo your comments, like, I'm using this a lot in my other day job. The systems around what we're dealing with is not fun, and the work is tough. But what gets me and many of us through the day is the people we work with and the approach they bring. So I just really want to acknowledge how important and valuable and fortunate we are to have you and your team and everybody who shows up in these meetings regularly and is here to help us move it forward together. I just want to acknowledge that's the good work, and it's hard work. It's not easy work, and this feels really daunting. And but there is a light there that's around the corner. So I just want to acknowledge the work, and there's a lot of continued transparency, and I would use the word radical candor collection of the last 20 years on different boards. of just how transparent, this leadership team is. Just thank you for all that.
Any other questions? Julie, I have a couple questions in the projections, the 4.2 and 5.6, and that's the midpoint of that's where we get the 4.9. So that is in the way that we projected that patients will continue to show up into our emergency room trying to get care and not have adequate health insurance in order for us to be reimbursed for services, right?
Yeah.
Is that mostly that 4.9 impact, or what else kind of factors into the estimate?
There are also reductions in what we are paid by Medicare and Medi-Cal.
Mhm.
So for those who retain their insurance, there will still be reductions in coverage. We'll also probably see lower volumes from
Right.
people who are not insured anymore.
And then for the IGT funds, can we run through it again with the two programs that we're going into this? I think it's good for public education and also just for education of the board as well.
Yeah.
The ones that we're purchasing in and expecting dollars back from.
The voluntary rate range program, which is first, is where we make a payment of just under $600,000 in November of this year. And that we will get back in about February, $1.4 million. So there's a net of 800,000. We do have some fees to pay for the consultant who has done all the steps to execute that agreement, but the majority of that is ours. We will kind of put that aside with money that we're saving up, because in April, we make a $2 million payment for the private hospital supplemental fund. And that comes back in June at $4 million. So that is the two new intergovernmental transfer programs that we are currently, this is our first time in those. And then the next year, it's our intention, if we can
Right.
be able to try to increase what we put in so that we can draw down for more funds. There are some caps to that, and that's where we work with the consultants as to what drives the amount you can put in.
And those are based on our care for Medi-Cal patients. So the first one is smaller, partly because it is based on the Medi-Cal patients that we serve in our clinic, which is part of the healthcare district. And so that is money that goes from the district and then back to the district to help compensate for care provided to the Medi-Cal population. And the other one is one that, as Julie mentioned, the private hospital supplemental program. That is money that goes from the district to then come back and benefit the hospital based on the hospital's care for Medi-Cal patients. So part of those caps for both of those programs is really about how Medi-Cal patients we serve on both the clinic and the hospital side.
And then a couple other questions, just overall in the budget. I think the number that I look at and it just like keeps me up at night, which I'm sure there's a lot for you guys as well, but it's the QAF 9 at 75%. If it's anything lower than that, I mean, what is that? It's tough to project.
It just gets worse, right?
Yeah.
We can extrapolate those numbers. So, yeah.
From a staffing services, I don't want to, go run through a bunch of different scenarios or whatever it is, but what would that mean for the hospital? Anything lower than like a 75% or even, I know that that's what we've heard is so far is 75% is probably what it's not a complete departure of the QAF program, but
The 75% is a swag,
yeah.
in order to put something in the budget.
Mhm.
With the understanding from our consultants as best that they can read the tea leaves at this point, that something should get approved, but it might not be the whole thing. But they really don't know. Nobody really knows. So we have to put something in there. So this is our best estimate. Even with that, as Julie mentioned, there's still a $4 million gap that initiatives are going to have to fill in order just to break even. And so that's gonna be some combination of, better staffing productivity, other cost saving opportunities, and other, revenue generation, right? So we haven't built in there yet the new orthopedic surgeon who's starting in December. We haven't yet built in the new general surgeon who's starting in January. As Julie said, we don't know anything about any kind of strategic partnership at this point. So we're not budgeting for that, but those would be potential initiatives that would help fill those gaps. If the QAF approval comes back even worse than 75% of what's modeled, then those gaps get bigger and those initiatives have to multiply to make it work. And those could be revenue generation or cost cutting, or more than likely both.
Right.
And it's very likely that we will be bringing a budget to the board to approve in December before that COF 9 approval
Very
is
likely.
in.
Right.
We're hearing December at the earliest, and with this government shutdown and other things that could fall into the first quarter. So, at that point, it will be a variance to budget, and it will be much like we do now. What do we need to do to just keep running the services at the rate where we're running them? It's gonna make sense.
I had another question, but I forgot. Should have wrote it down. Okay, that's all I have for now. I'll email you guys.
Thanks.
Okay, I will open this up for public comment. Anyone online wishing to speak on item number 8 on the 2026 budget update?
Not seeing any hands raised on.
Anyone in the public wishing to speak on this item? Okay, seeing none, I will close down item number 8, move us on to item number 9, the Watsonville Community Hospital Quality Report for October 2025. Michelle, thank you.
Oh, yeah.
My name is Michelle Mazaris. I'm the interim director for quality. Thank you for welcoming me. I did want to start in a similar way, but Andrew did, with a thank you. You guys are volunteers working full-time jobs yourselves and coming here at night to help make sure that this hospital is doing the things that it is doing so well. I live in a district that's covered by this hospital. I've worked in this hospital. I've worked in this hospital as a nurse on the 3rd floor, and thank you. I wanted to start with regulatory activity. In September, we had CDPH come by and do an HAI data validation. They were in and out in 4 hours, which we like. Get them out the door as quickly as possible. And they have no findings, so they were pretty happy. October kind of CDPH kind of activity that we've been doing, we updated our license with Trina's information as she is the new CMO. We requested that license for the MRI trailer that we are patiently waiting for. And then we also applied for a flex waiver for the cath lab so we can do more procedures. We did have the Joint Commission here in July. They were here for 3 days. They came back and resurveyed. I'll do a little more information on that in my slides coming up. And we also submitted our evidence of standard compliance, which is basically our corrective actions for any of the findings that we had. Included in this evidence of standard compliance was 2 limited time waivers, which are basically a request for an extension for bigger projects that need to happen, for both construction projects that are not scheduled to be completed until Q2 2026. This is the Joint Commission, basically their report card and our findings for the survey that they did. Among some of these findings, we have, compliance with our policy around our suicide patients. The processing of, the sterile processing of instruments. We have some environment of care findings, some life safety findings, a couple of medication findings, how we administer some of the pain medications and how we reassess for pain. All of these have had corrective actions filed with the Joint Commission. I wanted to take a little bit of a deeper dive in what we call, or what was labeled as the immediate threat to health and safety finding. This finding, I mean, before I start this, I'm gonna say that anytime I say NIFU, I am referring to a manufacturer's instructions for use. It's just hard to say it as many times as I need to say it in this presentation, so NIFU. What happened was they found that the way that we were sterile processing our instruments, we were using the MIFU for the sterile processor and not the MIFU for the actual instruments itself. Which they felt we needed to be using the one for the instruments. We instantly gathered up all of those items, those instruments, took them out of patient care. And all of this was done within, I think the Joint Commission was still on site when we were doing a lot of finishing up all of this stuff. The majority of the instruments in question were in the wound treatment center. So Liz jumped into action. Liz is the manager of the wound treatment center. And sterile processing as well. They did staff education, competencies. They figured out a process so that when the wound center is actually, going to sterile processing to pick up the instruments, they're double checking the instruments. And then in the wound treatment center itself, they are also just doing a daily inventory to make sure that those are processed properly. In sterile processing, in addition to the education and competencies, they also created a binder that has all of the instrument MIFUs in the binder. So if any of the sterile processing staff have questions about any of those instruments or how they should be handled, those MIFUs are readily accessible. I also want to add, the surveyors raved about the sterile processing folks. They said they know their stuff. They have great processes in place, and yeah, they did a really good job when they went through it and walked through that whole department. I was gonna say next slide, but I hate to do it. So this is just kind of the follow-up that the Joint Commission did. Because we had that immediate threat to health and safety, they came back within 23 days on, and the visit was actually on August 12th. And they came and looked specifically at the corrective actions that we had in place for the immediate threat, and they left happy. Things were as they wanted it to be. And then the second visit on the 27th of August was really focused on the other corrective actions that we had. And again, they were there for the wood surveyor one day, and she left happy. I'm going to start with just, I don't have a lot of data, but I do have some data. Healthcare acquired conditions, our trend over the last 3 years. The light blue is 2023, the purple or gray is 2024, and then the yellow, not a lot of yellow on that slide. There is 2025. We are doing a really, really good job at making sure our patients come in and don't get sick. So it's a great slide. I love it. And then the source for this information hasn't been updated since March of 2025. I'm going to make sure that the next presentation has more updated data. But basically, this is our all-cause readmission slide. It shows different periods, but the one that is most referenced or most important, not most important, but kind of, is the one that's all the way to the left. And that is the 30-day all-cause readmission rate. So we are in the blue, Watsonville Community Hospital is in the blue, and all other, the comparison would be hospitals in California, and we want that number to be lower, and we are. And then mortality all cause, again, we are in the blue, and we want that number to be lower, and it is. Oh, thank you for the HCAP data, Steve. And then just a little bit about some of the things that our department is up to. The quality focus has really been around survey management and the plan of corrections, making sure that we're supporting other departments that are doing the audits and stuff like that. It's a lot of work. We are doing our OPPE reboot. We actually are going to have our first set of report cards go out in November. So we're really excited about that. We're using a new software called MD Stat, so it will be electronic. That's also a very exciting thing. Peer review committees are back up and rolling, which is clearly that needs to be happening. In the world of risk, making sure that our grievance process is back up and running smoothly. We have time periods that we need to meet. Our response letters need to be out in a certain period of time, and making sure that all that happens. We also did have a risk assessment of our risk program by Beta, who's our insurance company. Compliance, we have restarted the compliance committee meeting. We've had 2 meetings since June 30th, and we have a new compliance line that we're going to be rolling out the next couple weeks. Employee health. We have a new nurse, program manager, pardon me. Med staff office, Maria Fernandez is our new interim manager. And we've done some credentialing over the past quarter. July, we did about 10 providers, August 13, September 13. And then in the world of infection prevention, our infection prevention program director, Monica Murphy, has been busy. We did a flu clinic with Shannon, but this is what I was referring to. And they vaccinated 50% of our employees with flu vaccine, which is good. And hygiene competency, she is like a dog with a bone. She's doing a real good job making sure people are out there washing their hands and doing it well. And then there is, of course, a mandatory masking mandate that will start off on November 1st, 2025 from the county. And she will let you know if you're wearing your mask wrong or if you should be wearing a mask. It's amazing. I walked around the hospital with her. It's like, oh, okay, all right. She's gonna let them know. It doesn't matter what you do, she'll let you know. And then last but not least, CDPH awarded Watsonville Community Hospital with a gold designation for antimicrobial stewardship. And this is definitely in conjunction. Jen did so much of this work, but infection prevention was involved. And as Jen likes to say, they can't take it away from us for 3 years.
And there will be a acute care facility in 3 counties that are gold, will have gold status. Just saying.
Good job. You did exactly what I wanted to see.
She says I'm still not getting one yet.
And then this is my last slide, just a little bit about what I'm hoping to do with the actual process improvement for next year. I'm wanting to work with each department to find some meaningful process improvement that's relevant to the actual department and actionable to each department. I'm going to create a template so that everybody is using the same way to report out. It'll be consistent. And I'm hoping that departments will share their progress monthly and then report out quarterly. That's my last slide. It's a true honor to be working here, so I really appreciate you guys and everybody. Any questions?
Any questions for Michelle?
You mentioned that they are an insurance company doing a risk assessment program review. Are they starting? When will it be done? Did that
It's
come back?
done, the report is pending. Yeah, they'll do all kinds of risk assessments for us. Yeah, we're hoping the next one is a work business. We're gonna have them. Yeah, yeah.
Any other questions for Michelle?
Just a thank you. I think this was a really nice overview of what you're working on, and it's helpful for us to understand all that hard work that goes into it. So thank you for doing that.
Thank you.
Any other? Can we go back to the slide, and I apologize, I didn't get we didn't have the printed copies, but can you go back to the slide with the hospital acquired or healthcare acquired conditions? I thought that was a really impressive slide. I just want to spend a little bit more time on. Yeah,
that's one.
yeah. So just the drop from 23 to 25, I just thought this was amazing, and I wanted to spend some more time, and I don't know if you can give any more context as to like the year to date from 23, having 37 down to 4 this year, and just the decrease in the drop throughout. I think this is really impressive. If you could add anything, or maybe give kudos to the rest of the staff or whoever else.
I mean,
had
absolutely,
yeah,
absolutely.
it'd be great.
So, we discovered with one of the, CDPH visits that, that we had earlier this year, that the HAPI, so the healthcare acquired pressure injuries, we were probably over-reporting a little bit on those.
Oh, interesting.
C. diff, their, the infection, Michael Kamei, worked with, no, he worked with the lab. He worked with the lab to make sure that doctors are ordering C. diff tests, which well, we won't talk about that. Anyway, that they were ordering them appropriately. It gets a little confusing because you can have a person that's colonized with C. diff and it comes back positive and then reportable at that point, not always. It's not always reportable. So it may have been a little bit of over-reporting there as well. Falls with injury, we have been working hard. Susan and Carrie, adult services, director and manager, worked really hard. I think we had a separate work group even where we, made sure that the bed alarms were all working. And if they weren't working, we had a pad. There's a pad that's also an alarm that you put under a patient. Making sure that the patients were being assessed properly, and answering those call bells. They did a lot of work on making sure the falls were a focus. Does that help answer some of those questions?
Yeah, I just look at I know this, we get some of this report in the HCAHPS, or we were getting it last year as we were talking about, having these as being our metrics, and it's just great to see them come back around and to see it this deep into 2025, and continue to see this good downward trend in these things. I'm just really impressed with the team. And, all the surveys come back, and, Steve made it a habit of including the Google reviews in there to remind the board that good things are happening within the hospital. And so just great to see all of this happening and knowing that people are being cared for, even if we're in a really difficult, tough financial time where, we don't have all the coverage that we need and all those other things right now. So this was great, to echo Alex and just continued thank you to you, to the rest of the team. I know that, a lot of our frontline staff don't come in unless it's a controversial issue, but I'd love to see them here so they could see these sort of numbers. And I hope we're communicating that out there and giving them thanks for all the work that they're doing. This is great. This is awesome stuff.
If I could add a couple things too, Michelle and Jen, you can expound on this too. I think with the the pressure injuries, we've also done a lot of work, respiratory therapy has done a lot of work on this, right? There were a lot of pressure injuries that were happening with the nasal cannulas and the things that you need to keep breathing while you're in the hospital that are like stuck to your face all the time, that can create those pressure injuries on the skin. And our respiratory therapy team has done an amazing job, like really honing in the process around that to make sure that there's protective things there, that they're being moved around so that pressure injuries are not happening anymore, with those kinds of, pieces of equipment. Falls with injury, we've done a lot of work to make sure that our bed alarms are working and functioning and attached to the beds and not ripped out of the wall, and things like that. So that was an issue, right? Where we didn't have a bed alarm. Patients were, getting out of bed and we didn't know it.
Mhm.
So, yeah.
Yeah, thank you for the reminder. Liz, our wound treatment center, manager, she has a head, just a head with a beard. And you know, if she's carrying that around, they're doing some education around it, getting a good seal on a BiPAP.
Yeah.
That was actually their joint PI for a couple
Yes.
of years, so their performance improvement was a joint between respiratory therapy and wound treatment. So we saw not only, to Steve's point, addressing and changing some of the equipment and the pieces that they were using, but the communication improved. As soon as somebody gets put on a certain type of BiPAP or ventilator, they automatically text the wound nurse to let them know.
Right.
They have better communication and documentation in the chart. They work on that.
Even in safety huddle, every morning, we know which patients are on BiPAP for that reason.
And the wound nurse already knows. You know, we're saying it to make sure that they know, and they already know, they already followed up, so. Yeah, it was a really good PR, because that was a win.
Just excellent work, just awesome, thank you.
Yeah, of course.
I don't have any other questions. Any other questions for Michelle? No, okay. I do want to take public comment for this and then we'll wrap up this meeting. So, anyone wishing to speak on this item number 9, the Watson Community Hospital quality report for October 2025? Anyone online?
No hands online.
Anyone in person? Okay, I'll close down item number 9 and adjourn our Watson Community Hospital board meeting.